So, you all should know to draw this picture. If this question is asked in the theory exam, it's better that you all learn to draw this various sections of the brachial plexus, like the roots, trunks, divisions, cords, and branches. There are a lot of mnemonics to remember that. So the roots of that, it is the anterior primary rami of these five nerves, T5, 6, 7, 8, and T1. What happens to the posterior rami? Usually it is described that the anterior primary rami of the five cervical, I mean four cervical and one thoracic spinal nerves form the brachial plexus. But every spinal nerve divides into an anterior or ventral ramus and a dorsal ramus. So what happens to the posterior rami?
Sir, they take out the sensory information from they carry the sensory information, sir. The motor.
Carrier of sensory information. It is a mixed spinal nerve which comes out and divides into an anterior and a posterior rami, isn't it? Or ventral and dorsal branches. So the ventral branch only forms this brachial plexus. What happens to the dorsal or posterior branch? Right, we will see that later. The nerves pass between the anterior and medial scalene muscles to enter the posterior part of the posterior triangle of the neck. And the branches at the root, trunks, and cord level, they are also important. Dorsal scapular nerve, the long thoracic nerve, arise from the roots of the brachial plexus. The suprascapular and nerve to the subclavius originate from the superior trunk, and the lateral pectoral nerve arise from the lateral cord. The medial pectoral nerve, medial cutaneous nerve of the forearm and arm arise from the medial cord. So these are all considered as other branches or smaller branches compared to the five terminal branches. And superior subscapular and inferior subscapular nerve and thoracodorsal nerve arise from the posterior cord. And the three cords, the posterior, medial, and lateral, are formed from the anterior and posterior divisions. All these pictures will tell you. And their relationship to the second part of the axillary artery. That is the relationship, anatomical relationship. Of course, they travel over the first rib area also. And how many major terminal branches are there and where are they formed? Describe them. It is in the axilla. So the final branches are arising at the level of the axilla and the proximal aspect of the upper limb. There are and the three cords give rise to these five branches. And they are musculocutaneous, which has a root value of C5, C6, and 7. And their motor function innervates the brachialis, biceps brachii, and corpobrachialis. And their sensory function is to give off lateral cutaneous branch of forearm, which innervates the lateral half of the anterior forearm, the smaller lateral portion of the posterior forearm. Then the axillary nerve, which has a root value of C5, C7, C6. Motor function innervates the teres minor and deltoid muscles. And sensory function gives off a superior lateral cutaneous nerve, which innervates the inferior region of the deltoid, which is called the regimental badge area. And median nerve with the root value T6 to T1. And motor function innervates the flexor muscles of the forearm and thenar muscles and two lateral umbilicals. And the sensory function gives off the palmar cutaneous branch, which innervates the lateral part of the palm and the distal cutaneous branch. And the radial nerve, this is the only nerve that has all the roots, T5 to T1, because it is made from the posterior divisions of the trunk. So that is the reason why it has all the roots of the brachial plexus. And it mainly innervates the triceps and the posterior compartment of forearm, which is primarily the exclusively extensor of the wrist and fingers. And their sensory function innervates the posterior aspect of the arm and forearm and the posterolateral aspect of the hand. And ulnar nerve has got a root value of C8 and T1. Motor function innervates the muscles of the hand apart from the thenar muscles and two lateral umbilicals. It also There is the flexor carpi annualis and medial 1.5 fingers on the hand on the palmar aspect is also innervated by that. So this picture is a very good picture I picked up from the net. Yes, all the roots and their branches. So from C5 you can see dorsal scapular nerve is coming, and you can see the long thoracic nerve arising from the roots C5, C6 and C7. And so if the root value it is given, and the first intercostal is also given off from T1. And at the superior trunk you have the suprascapular and two subclavius muscle. And so the other two trunks do not give any branches. So only superior trunk gives the branch, and then it divides into anterior and posterior divisions. All the posterior join to form the posterior cord. And from the lateral cord, you have the internal pectoral nerve, which has a root value of C5, C6, 7, which supplies the pectoralis major muscle. And posterior cord gives the upper subscapular and lower subscapular, which are also part of the posterior supply of the shoulder. And the thoracodorsal is also supplying the back region. And the medial cord, of course, gives the smaller branches like the medial pectoral, medial cutaneous, and of now of arm and forearm. So they all arise at the cord level. And finally, these main 5 branches are there, and they give right. So all these root values, everything is given. So 5 roots, 3 trunks, and 3 cords and 5 branches. So the another mnemonic is 5-3-3-5. So the divisions you can forget because the trunk divides into anterior and posterior. So if you remember 5-3-3-5, then it is easier to describe the whole anatomy in your answer. So this Erb's palsy is also I just mentioned here because it is a specific type of brachial plexus injury occurring at birth because of the damage of the upper region, C5 and C6 during difficult delivery. So it will be at this level, which is the injury site will be there, and patient will have a what is called the policeman tip receiving position with a flail limb. And the severity of Erb's palsy is determined by the severity of the nerve injury. So the nerve injuries, all of you might be knowing that they are all classified into 3 types: neuropraxia, axonotmesis, and neurotomesis. Neuropraxia is the most simplest form of injury, which is just a stretching of the nerve, and invariably it recovers very nicely without any residual lesion. And axonotmesis also can recover, but will take a longer time. And neurotomesis is the one which requires some intervention to re-anastomose because the whole nerve is severed or disrupted. So these are the 3 types of injury which determines the severity of the lesion. So neuropraxia, axonotmesis, and neurotomesis are the things. Now coming to the description of how to perform the block is performing without ultrasound, or the anatomical landmark based technique is the one which I am describing here. The interscleral block is indicated for procedures on the shoulder and proximal humerus also, and lateral part of the clavicle. And you can describe it in steps like this. The patient is placed in supine position with the head turned away from the side of the block. And then patient is asked to elevate the head slightly to bring the clavicular head of the sternocleidomastoid into prominence. Then the index and middle finger of the non-dominant hand are placed immediately behind the lateral edge of sternocleidomastoid. And the palpative fingers are rolled laterally across the belly of the anterior scalene muscle until they fall into the scalene groove formed by the anterior and posterior scalenal muscles. And the external jugular vein invariably crosses this scalene groove. And the skin is anesthetized with 2 ml of local anesthetic subcutaneously. And then the needle is inserted just posterior to the external jugular vein, approximately 3 to 4 centimeters above the clavicle, and advanced at an angle of perpendicular to the skin. You can elicit paresthesia, or if you are using a peripheral nerve stimulator, you can stimulate the nerves and see the movement of or attraction of the deltoid. And 30 ml of local anesthetic can be injected after repeated aspiration. The advantages of this technique are it produces good analgesia for post-op pain, reduced opioid usage. They can be used as a sole anesthetic for shoulder surgery. And the disadvantages of the bleeding hematoma or epidural or subarachnoid injection, local anesthetic toxicity if it is directly injected into the vessel, Horner syndrome, phrenic nerve palsy, and sparing of ulnar nerve, which is usually missed in the. So that is the reason why it cannot be used for distal forearm or the distal upper limb surgeries. And the Frohman sign is a clinical sign of ulnar nerve palsy exhibited as a weakness of the thumb's ability to pinch. And as he described the procedure, this is the normal hand where you are able to tightly hold this paper with a straight thumb. On the contrary, if the ulnar nerve is paralyzed, the patient will usually bend the thumb like this and hold the paper. So this is the classical sign, what is called the Frohman sign, described by the inventor, what is ulnar nerve. Okay, so that completes the description of all these things.
Right.